Добрий вечір всім. Пані Ірино, прошу, розпочинайте.
Доброго вечора, шановні учасники нашого вебінару, шановні колеги, партнери, співорганізатори. Сподіваюся, що ви, наші друзі, медичні працівники України, які беруть участь в вебінарі, а вже достатньо велика кількість зайшла в камери в онлайн, що ви знайшли безпечні для себе і зручні місця. І ми розпочинаємо третій вебінар з проєкту «Спеціалізовані послуги для дітей і підлітків у сфері ментального здоров'я». Цей проєкт є складовою частиною всеукраїнської програми ментального здоров'я «ТЕЯК». Ви знаєте, мабуть, що програма є ініційована першою леді України Оленою Зеленською. І, власне, в реалізації всеукраїнської програми ментального здоров'я таким суперпріоритетом є посилення професійної спроможності, знайомства з кращими практиками нашої професійної спільноти. Ми окремо працюємо з спільнотою фахівців у сфері дитячого здоров'я, ментального здоров'я дітей, адже всі ми прекрасно розуміємо, наскільки важливо для нашої країни, для цілого світу стійкість, професійне психічне благополуччя кожної дитини, за ними наше майбутнє. Звісно, що цей проєкт не був би можливим, якщо б завдяки силі лідерства першої леді ми не могли залучити міжнародне партнерство. Зокрема, в особі Європейської комісії, Дитячого фонду ООН ЮНІСЕФ, інших наших потужних партнерів. І серед таких партнерів є Європейське товариство дитячих психіатрів. Ми надзвичайно вдячні професору Jörgu Фегерту за особисту залученість до впровадження програм для підвищення професійного зростання дитячих психіатрів. В рамках цієї програми, підпрограми «Спеціалізовані послуги для дітей і підлітків у сфері ментального здоров'я», завдяки ініціативі професора Фегерта, його міжнародним контактам, Європейському товариству, ми змогли провести вже 2 попередніх вебінари, і також представницька делегація дитячих психіатрів України взяла участь в міжнародному потужному конгресі, який нещодавно відбувся в Німеччині. Сьогодні наша увага зосереджена на вкрай важливій темі – травмі та посттравматичному стресовому розладі, який ми знаємо як ПТСР, який кодова, можна вже сказати, назва, якою інколи маніпулюють, і нам надзвичайно важливо правильно розставити акценти, правильно зрозуміти підходи до діагностики, до лікування, до ведення таких пацієнтів. У цей час, коли Україна переживає надзвичайно серйозні випробування, ми практично 1000 днів знаходимося в марафоні повномасштабної активної військової агресії через випробування військових конфліктів і їх наслідків. Питання ментального здоров'я наших дітей набуває особливого значення, а травматичні події глибоко впливають на чутливу психіку наших дітей і підлітків, і це приводить до повсякденних викликів, які ми з вами разом долаємо. На вас, на фахівцях, які працюють з дітьми, величезна відповідальність, величезне навантаження. Поглиблене розуміння ПТСР, його діагностики, методів лікування є ключовим у забезпеченні ефективної, своєчасної і якісної допомоги дітям. І ми маємо сьогодні унікальну можливість здобути нові знання, новий досвід, рекомендації від професора Andrea Danese з King College London, видатного експерта, провідного експерта у галузі дитячої травми і механізмів стійкості, які допомагають подолати наслідки травматичних впливів. Власне, завдяки своїм глибоким знанням і багаторічному досвіду у лікуванні і консультуванні дітей з ПТСР від пана професора ми зможемо краще зрозуміти, як формуються ці стани, які стратегії можуть бути корисні для лікування і подолання. І ці знання допоможуть підготувати наших медичних працівників, яких представляє аудиторія поважна сьогодні, наших освітян, батьків, всіх, хто працює з дітьми, до кращого розуміння і застосування ефективних підходів у наданні спеціалізованої фахової допомоги. Участь кожного і кожної у цій зустрічі є надзвичайно важливою частиною нашої спільної місії підтримувати і зміцнювати ментальне здоров'я нашої молоді. Від імені Координаційного центру з психічного здоров'я Кабінету міністрів України, який супроводжує впровадження всеукраїнської програми ментального здоров'я, я маю честь подякувати нашим спікерам, подякувати Європейському товариству дитячих психіатрів, нашим партнерам в особі Дитячого фонду ООН, ЮНІСЕФ, Міністерства охорони здоров'я, Національної служби здоров'я України, а особливо усім, хто приєднався, усім слухачам, усім фахівцям, хто приєднався сьогодні до нас, за активну участь, за підготовку і найголовніше за готовність сприяти зміцненню ментального здоров'я наших дітей і розбудови сфери психосоціальної підтримки українських дітей. Ми переконані в тому, що цей вебінар стане ще одним важливим кроком на шляху до нашої з вами перемоги. Дякую всім і, Катерину, прошу, передаю вам слово.
Добрий вечір всім. Добрий вечір, професор Фегерт. Добрий вечір, Andrea, Danese. І ми дуже дякуємо всім, хто приєднався до нас в вечірні часи. Організаційно просимо вас ще раз підписатись на сторінку координаційного центру у Фейсбуці, щоб ви спостерігали за всім важливим, що відбувається, на телеграм-канал пані Ірини Mykychak і також на мій YouTube канал, де зберігаються, доктор Булавінова він називається, де зберігаються всі ці відео. Будь ласка, для тих ваших колег, які не знають про те, що такий цикл відбувається, просіть їх реєструватись, відсилайте їм лінки на всі ці відео. І якщо, наприклад, хтось хотів, не встиг, не добіг, був десь, не знаю, у лікарні, не міг, ви теж можете їм надсилати відео, щоб вони їх дивились потім не в прямому ефірі, а в запису. І є в нас як оригінальна доріжка, так і доріжка з перекладом для тих, хто як любить дивитись. І наразі передаю слово професору Jörgu Фегерту.
Thank you very much, Kateryna. Iryna Mykychak, thank you again for having us with that webinar series. And dear colleagues in Ukraine, I'm overwhelmed that again, more than 260 persons are attending live, and I hope that registration of the video will help others to see the important content that Andrea will bring to us today. I hope that the last webinar that I couldn't attend, and it made no sense because it was in Ukrainian by Danese, was of help for you. Today, I'm very glad that Andrea Danese, who is distinguished professor in child psychiatry, works at King's College, as Iryna Mykychak already mentioned. He's also the General Secretary of ESCAP, of our European Society, and we work very close together. He works at the Institute of Psychiatry, Psychology and Neuroscience at King's College in London, and is also Professor Adjunct at the Yale Child Study Center. His team and he published very highly cited research on the measurement of childhood trauma, risk factors for trauma exposure, biological mechanisms of resilience, and all these things that are important for you now in that situation. Therefore, we thought that starting that series, it's really important to talk about trauma and PTSD and stress and coping about stress. And I asked all the speakers to be also very practical, to be didactical, to explain things, but to be also very practical. And I hope that in the end, we will have the time to discuss many, many things. Andrea is among the really highly cited researchers in psychiatry and psychology and is listed on that list since 2019. He has built up a national specialist child and adolescent mental health service clinic for trauma, anxiety, and depression at the south of London, Maudsley, and NHS Foundation Trust. And he advised the UK government in this public health reaction sector in the aftermath of emergency and disasters, and also to the war situation now. Professor Danese is not only our academic secretary, but he is also at the Royal College of Psychiatrists Faculty of Child and Adolescent Psychiatry, the academic secretary. So that's a good link, and he is editor at several scientific journals. So I didn't promise you too much. We have really the expert in childhood trauma today, and I'm looking forward to your talk, Andrea.
Thank you very much, Jörg, and I'm really delighted to join you today and to share some of our understanding of assessment, screening, and treatment for childhood trauma. And I hope, as you said, that we'll have a chance to then have a discussion at the end of this presentation. So I will share my slide. That's right.
Andrea, we will now share you and your slides on the screen, and we have already 255 people in Zoom. So Andrea.
Perfect. Can I just check you see my slides?
Let's just check. For the moment I can see you. Yes, now I can see you and the slides. Okay.
Perfect. Right, so yes, today I will focus on discussing childhood trauma and trauma-related psychopathology. There are some disclosure, but I can see that Jörg very kindly already made those ahead. And so I will focus on these three aspects of our current understanding of assessment, detection, and intervention for trauma and trauma-related psychopathology. And so we will start discussing the assessment of trauma and trauma-related psychopathology. So to begin with, I think it's always really important to define how we think about trauma. And sometimes people are perhaps surprised of how narrow the definition of trauma currently is. So focusing, for example, on the DSM-5 definition of trauma, really we think about events where the person was exposed to, I'm not sure what's happening. There we go. To death, threatened death, actual or threatened serious injury, or actual or threatened sexual violence. And importantly, the exposure to trauma can be direct, can be witnessed, or can also be indirect. This is what we call network trauma. That is, people learn that, for example, a relative or a close friend are exposed to trauma, but do not directly experience or witness that exposure. And so this is quite a narrow definition, but is the definition that we will use and is the definition that defines the criterion A for a diagnosis of PTSD. Now, to begin thinking about assessment, I will tell you a bit about some epidemiological work that we and others have undertaken. And to begin with, I will focus on some of our epidemiological work, which has been undertaken in this cohort called the Environmental Risk Longitudinal Twin Study. And you can see there Dr. Steph Lewis, who was a PhD student in my team and now is a research fellow at the Institute of Psychiatry. And she has led many of these epidemiological studies. So the ERISC study is a population representative birth cohort of about 2,200 twins born in England and Wales in 1994-95 that has been followed up to age 18 with 93% retention. And retention is really important when we think about trauma because we tend to lose in long-term cohorts many of those young people who would be exposed to trauma and live in disadvantaged socioeconomic conditions. So having high levels of retention gives us confidence that the results from this study can be then generalized to the wider population. And I will focus on mental health assessment of this cohort at age 18. And to begin with, I wanted to give you some idea about the epidemiology of trauma in the UK. And so in the UK, we have asked young people and young adults in this cohort to tell us about their own exposure to trauma up to age 18. And what we found is that about a third of them reported exposure to trauma, again, this narrow definition of trauma, up to age 18. And importantly, when we think about trauma, we want to think about both normative as well as abnormal responses. What I mean by it is that virtually all children and young people, as well as adults who are exposed to traumatic experiences, will show some responses to these experiences that are very normal, right, and should not be pathologized. For example, children and young people may become more clingy, may become more tearful, may report H's, may be upset or inattentive or tired or avoidant or persevering in doing some of the activities. And again, these are very normal responses to traumatic experiences. And they're common, and they will subside within days or weeks in most children. So observing any of these responses, again, it's absolutely normal and common, and that's a way in which psychologically children and young people try to cope with these experiences. Now, when symptoms persist for more than a month and impair the child's functioning, for example, how they function at school or their ability to socialize with peers, children may then meet criteria for other symptoms and particularly disorders, including post-traumatic stress disorder. And so if we think about post-traumatic stress disorder, you see, we need to, in addition to the exposure to stress, we need to really think about these three key dimensions of relieving, avoidance, and physiological hyperarousal. So the relieving cluster of symptoms is really the key symptom cluster in PTSD, because PTSD is very much a disorder of memory. So when we think back about neutral and positive experiences, we typically are in full control of what we do. And so what I mean by it is that we decide when we start recalling these experiences and when we start, when we decide to then move on and access other types of memories or the current experience. However, what happened in the case of negative experiences, and particularly traumatic experiences, is that sometimes the memories come up into our mind when we do not want them to come. And of course, these are very distressing memories. And because they're distressing and they're intrusive, so we don't have control over them, people and young people tend to feel really not in control of their mental functioning. And that's really a very scary experience for them. The memories typically are very vivid, and children might feel as if things are happening again. Although full flashbacks, that is, experiences that are related to dissociation, are not always present in children and young people. And the memories may also play back during sleep in the forms of nightmares. Now, because then there are these distressing, intrusive memories of the traumatic events, we see that children and young people adopt a set of different strategies to avoid having these memories. And therefore, they may engage in a set of avoidance strategies. For example, they may avoid places, they may avoid people, they may avoid locations and smells even, where we, I'm not sure, okay, that might remind them of the traumatic experiences. It may also be quite a covert type of avoidance, where people, instead of clearly showing avoidance of places, for example, might engage in mental exercises to try and avoid having those memories again. And of course, because there are those memories and because avoidance typically is not a very effective strategy to prevent those memories from coming back again, then many people who then develop PTSD perceive that the threat is ongoing, even though the experience might have finished. And therefore, they perceive ongoing threat, and the perception of threat, as well as the memories, might disrupt their attention. For example, when they try to focus on schoolwork or try to just play with their friends. It might disrupt their ability to control their emotions, and therefore children might become very irritable, very upset, sometimes violent even, and might disrupt their sleep, as we said already. So these are the three real dimensions of the assessment of PTSD. Now, what I wanted to share is that in our epidemiological work, we see that about 8% of the population in the UK, that is about 25% of those with trauma exposure, develop PTSD across their life course. However, the prevalence of PTSD, of course, might vary in the population depending on a set of variables. On the one hand, it may be that trauma exposure, of course, instead of being 1 in 3, like we have seen in the UK, might go much higher, up to 100 in situations, for example, of population-wide emergencies and disasters, including war, at least in certain regions. And so if we keep the same level of, the same rates of PTSD in those who have trauma exposure, then we move very swiftly from 8% to 25% prevalence. That is, 1 in 4 young people in the population may develop PTSD, for example. It is also true, and I will tell you more in a minute, that depending on the type of exposure and depending on the resilience factors for individual children, the rates of PTSD in trauma exposed may increase. And therefore, instead of, for example, affecting 25% of those with trauma exposure, they might affect, for example, up to 60% of those with trauma exposure. And therefore, if everyone is exposed to trauma, up to 60% of the population might develop a diagnosis of PTSD. So PTSD can be very common in the population, and therefore is a very important target for assessment and treatment. However, it's also important to take a broad view when we do assessment of psychopathology that might be related to trauma exposure. So in this case, I will discuss the prevalence of different types of mental health problems you see here in the slide in 3 groups. First, in the overall sample. So this includes young people who had and people who did not have exposure to trauma. So you see that in the population, PTSD is, in this case, we're looking at the 12-month prevalence. So the rate of PTSD is about 5% over past 12 months. And you see that the more common types of psychopathology, as you would expect, are major depression, as well as externalizing problems, such as, for example, conduct disorders and alcohol dependence here in the UK. Now, what I will do is to look at the prevalence of these same conditions, but in young people who reported trauma exposure, to see how the trauma exposure changes the rates of psychopathology across these multiple diagnoses. And so this is what we observe when we focus our analysis in those young people who do report trauma exposure. So you see that, first of all, there is, as you would expect, an increase in the prevalence of PTSD. But importantly, you see that there is an increasing prevalence in pretty much all the diagnoses that we have measured. And this is a very important lesson in the presentations in trauma-related psychopathology and in children who had trauma exposure. That is, PTSD is not the only condition affected, and in many ways is not also the most common condition. You see that conditions that had the higher base rate, including depression and conduct disorder, are also more prevalent in those with trauma exposure. Yeah, so this really reminds us that when we assess young people who report trauma exposure, we must be careful in the assessment of PTSD, but also we must be broad and assess all sorts of other conditions. Now, the next set of analysis will focus on young people who not only reported trauma exposure, but also developed PTSD, so post-traumatic stress disorder. And this is what we observe. So again, PTSD leads to significant increase in the rates of different types of psychopathology. And you see again, depression is the most common comorbidity in children and young people who have a diagnosis of PTSD. More than half of young people with PTSD diagnosis also have a depression diagnosis. And if we put together all the diagnoses that you see here, we would find that more than 3/4, more than 75% of young people with PTSD will have a comorbidity. So this reminds us again that in children and young people who have been exposed to trauma, as well as in those who have PTSD, we should expect comorbidity. And beyond the assessment of PTSD, we need to be broad and evaluate different types of psychopathology. It's not just about psychopathology, but we know that trauma and PTSD are also important risk factors for risk as well as functional impairment. And so if we look at trauma-exposed young people, for example, you see that there is an increased rate in self-harm, suicide attempt, violent offense, and NEET. NEET means not in education, employment, or training, right? So it's a very tangible measure of functional impairment in the population. And these are high rates. So we see that about 1 in 4 self-harm and 1 in 10 has attempted suicide, for example. And the rates of all these measures increase even further if we focus on young people with a diagnosis of PTSD, so that about half of them would have self-harmed, about 1 in 5 would have attempted suicide, about 1 in 10 also had records for violent offenses, and about 1 in 3 was not in education, employment, or training, really highlighting both the risk and impairment associated with PTSD. These are levels of risk and impairment that we would see in other serious mental conditions, including psychosis and severe depression, for example. Now, I mentioned earlier that the prevalence of PTSD and other types of trauma-related psychopathology can vary depending on a set of parameters. And one of them is the type of trauma. So not only we want to assess whether there is an exposure to trauma, but it's also important to try and clarify which type of trauma children have been exposed to. So if we look in the population, you see that there is roughly an equal distribution across these different types of traumas. So direct interpersonal trauma, direct accident or illness, witnessing interpersonal traumas, witnessing accident or illnesses, and network trauma. Again, network trauma is when we learn about other people's exposure to trauma, but we don't witness or are directly affected by it. Now, importantly, we see that these different types of trauma are differentially associated with the risk of PTSD. So if we repeat these analyses in young people who have PTSD, we see that types of trauma that are direct and interpersonal are overrepresented among those with PTSD, whereas, for example, network trauma are underrepresented. So this suggests that certain types of traumas that are interpersonal and direct, are more likely to lead to PTSD compared to other types of trauma. And that's why it's really so important to make a careful assessment of the trauma exposure or exposures, because of course, in many cases, there are multiple types of trauma exposure. Now, building on that, we can also look more broadly at psychopathology, as we have done in previous slides, and compare different types of trauma. So we can compare, for example, complex and non-complex trauma. And we define complex traumas that are interpersonal. We saw in the previous slide that those are very often more leading to higher rates of psychopathology than other types of traumas, and are happening in childhood and adolescence and are repeated over time. So that's what we call complex trauma, interpersonal, repeated in childhood or adolescent. And so we can compare the impact of these different types of traumas, and we see, for example, there are different impacts on a general measure of psychopathology. This measure includes all the diagnoses at once. And we see that complex trauma is associated with greater rates of psychopathology, of general psychopathology compared to no trauma. Also, it's associated with greater rates of trauma compared to non-complex trauma. We can repeat the same analysis looking at the count of different psychiatric diagnoses, or also at each of the psychiatric diagnoses that we looked at previously. And we have a consistent pattern where complex trauma is associated with greater rates of psychopathology compared to both no trauma, but typically also compared to non-complex trauma. Again, highlighting how important it is that we make a careful assessment of the exposure to trauma. Now, the other factor that really influences the prevalence of PTSD is the set of resilience and vulnerability factors in individual children. So to give you an example, we know that traumas that, for example, are witnessed versus direct, and that happens only once compared to happening multiple times, are typically associated with lower risk of psychopathology. But also there may be resilience factors. For example, children might experience trauma, but may also have a strong family support. And despite exposure to trauma, they might be able to go back and experience normal daily activities. So in this situation, despite the exposure to trauma, we would expect that the rates of PTSD and other types of trauma-related psychopathology would be lower, compared to, for example, a situation like this one, where the trauma is interpersonal, happens multiple times, perhaps is ongoing. It's also associated with loss and grief and separation. And beyond the trauma, the child might lose important resilience factors, including, for example, support from parents who might themselves have developed psychopathology, might be in situations where they are forced to displace and go away from the places where they live, and they may see their routines disrupted. Now, in these conditions, we would expect that the rates of psychopathology would be higher because we have more severe forms of trauma, but also importantly, we have loss of resilience factors. And we will come back to the idea of resilience in thinking, of course, about how we can try to foster resilience in the interventions. Now, I can provide some idea of the prevalences in trauma-related psychopathology that are relevant really to Ukraine, thanks to a cohort study that was undertaken and published just this year. So here we have the rates of exposure to war and other types of psychological traumas. These are lifetime exposures. And here we have the rates of probable psychiatric disorders, including PTSD, moderate depression, severe depression, and moderate and severe anxiety. So you see that compared to the rates that I mentioned earlier, these rates that are current rates over the past 2 weeks have increased, as we would expect, because, of course, there is a very challenging combination of both significant trauma exposure as well as, in many cases, loss of those resilience factors. So we would expect that the prevalences in the population are higher, as we see here, compared to the prevalences that we have observed, for example, in the UK. So to summarize this epidemiological data, is important to appreciate the differences between normal and abnormal responses to traumatic experiences. And it's particularly important to recognize the normal reactions because it's unhelpful in many ways to medicalize the distress that some of the children might have. But it's equally important to recognize when these reactions are abnormal and need to be addressed and targeted with some interventions. We saw that PTSD is a common and serious mental health condition, but is not the only or the most common type of trauma-related psychopathology. So the assessment in children who report exposure to trauma need to be broad and not just focus on PTSD. And also the formulation needs to consider both the strength and the vulnerabilities in individual children and young people to be able to then plan and deliver relevant interventions. Now, we have looked at the prevalence of trauma and of trauma-related psychopathology. One important piece of information, though, is how much the exposure to trauma and trauma-related psychopathology might lead to service use. And again, this is work in the UK, but we'll see the implications for it and for the realities in Ukraine at present. So in the UK, where there is a universal healthcare access, children and young people who report trauma exposure largely have no contact with any health professionals. Only 20% of them have contact with any health professionals and only 10% of them with a mental health professionals. And this might be okay because we saw that not all of them will develop psychopathology. But the reality is quite similar also for children and young people who do develop PTSD, which, as we just saw, is a very severe and impairing mental health condition. So you see that only about 20% of young people with a diagnosis of PTSD seek contact with a mental health professional. So there is an important divide between the symptoms that are experienced by young people and their ability to seek and then access adequate and evidence-based treatment. And there are many reasons for this divide, many barriers to healthcare access. On the one hand, there are very important psychological barriers. So it's very common to see trauma-related emotions such as shame and guilt in children and young people who are exposed to trauma, and shame and guilt might prevent them from seeking support from health professionals or even from their parents. There are cognitions about distrust and hopelessness. There are behaviors that, as we saw, are very much part of the issues in the diagnosis of PTSD, such as avoidance or inactivity. And then there are also developmental issues related to perhaps early age or neurodevelopmental differences and delays. So these are all psychological barriers to accessing healthcare. There are cultural barriers that are very important to map and understand and address. They might include limited mental health knowledge in the population, stigma around mental illness, and also concern about being stigmatized by others. These are all barriers to healthcare that we see very much in our population here in the UK, and they have been described internationally. There may be then other more structural barriers that are present in the UK, but maybe even more impactful in the reality, for example, in Ukraine at the moment, so that there may be disruption to the transportation system or disruption to family and community networks or scarce local capacity in child and adolescent mental health, perhaps limited availability of resources or mental health professionals with the relevant language skills, and perhaps the rapid rise in demand that would overwhelm the services in most cases. So to at least partly address these issues, so these are very complex issues that need to be addressed in multiple different ways. But one way that we know it's helpful is to think about screening. So population level screening, for example, for trauma exposure, to understand how much this has affected individual children. And the child trauma screen is one of the instruments that we have used in the past here in the UK. And then it's important not to stop at the level of screening for traumatic experiences, but also screening for psychopathological symptoms that might then predict or highlight the impact on psychopathology. For example, we might want to assess PTSD symptoms with the Child Revised Impact of Events Scale, and anxiety symptoms with the Revised Children's Anxiety and Depression Scale, and also more broadly behavioral problems with the Strength Difficulties Questionnaire. So as a brief summary for this section, trauma and trauma-related psychopathology often go undetected and untreated. This is true for the UK, as we have had a chance to study, but is also the case for most of the other countries, including, I imagine, the current reality in Ukraine. It is important to gain local knowledge to map key barriers for healthcare access in order to improve the detection and treatment, so to go against those set of barriers that we have seen in previous slides. Simply screening for trauma exposure is inadequate and inefficient to identify individuals at risk of trauma-related psychopathology, and therefore we need pragmatic approaches that also use screening for symptoms of trauma-related psychopathology. Now, there are important challenges, of course, and one of them is the feasibility of providing treatment to those who screen positive. Ethically, I feel screening is feasible and justified if we can then provide treatment. So ahead of doing and planning for population screening, we need to ensure that there is treatment that can be delivered for those who screen positive. It's important to consider how population screening can be implemented, ideally as part of existing public health efforts rather than as a separate initiative. It is important to think whether screening is accurate enough to provide clinically useful framework for action. That is, that we can identify with a good degree of certainty which children and young people have or will develop in the short term symptoms of psychopathology. And finally, of course, there are very pragmatic challenges, including the presence or the need for valid translations in local languages, for example, of those rating scales that I mentioned earlier. All right, so I said already that I feel screening is key, but screening requires the presence of effective interventions to be ethically delivered. And so it's important to then also consider what interventions might look like. And when we think about interventions in the same way, I mentioned it for the assessment stage, also for the intervention stage, we do need to think broadly. As I said, there are some initial responses and some symptoms that may be normal, and they're very common. And then some of the children and young people will develop trauma-related disorders as well. And so it's important thinking about intervention to both consider treatment, but also prevention and building resilience in children in the population. Now, for today, I will also want to highlight the Interagency Standing Committee Pyramid of Needs that really is the framework that most humanitarian agencies use to plan this broad set of interventions, which includes building resilience, so having basic services and security, community and family support, and focused and no specialist support, but also specialist services for those who do develop a disorder and need to access clinical services. And as you can imagine, the amount of population that can be supported through these initiatives is reduced as we go up in this pyramid. And so the increasing level of formal training and supervision and skill and competencies increases also as we go up this pyramid. But in all these aspects, I think clinicians need to and can have a role. So, of course, we are familiar with how clinicians can provide treatment interventions in their specialized services, but it's also really important for clinicians to be empowered and consider the role in supervising and coordinating lower intensity interventions that can have very big public health impact in the population. And this is very much in line with the suggestions from the very recent Lancet Commission on Mental Health in Ukraine that highlight very much the role of community mental health services and mental health in general healthcare. So really thinking about systems that, of course, include specialist service provision, but also include other types of interventions. If we focus on the specialist interventions for the remainder of the talk today, we can discuss what is the evidence base for the provision of trauma-focused therapies. And the evidence, particularly in children and young people, really is for psychotherapies in this age range. In particular, we have these types of psychotherapy, so particularly the trauma-focused cognitive behavioral therapy, the narrative exposure therapy, but also EMDR. These are evidence-based interventions that have been proven in randomized controlled trial to be beneficial in children and young people who have developed PTSD. They are based around cognitive elements of treatment that aim to challenge and help beliefs that children and young people may have about the event, about themselves. We discussed earlier emotions of guilt and disgust, for example, and others, again, challenging cognitions about ongoing threats. They also have elements that are behavioral, so that they aim to reduce the avoidance of traumatic memories, so that those traumatic memories may be reprocessed and may be perceived in a less distressing way. Now, there are also other more general elements that are present in these evidence-based treatments and in other forms of treatment, and they include emotion regulation skills and focus on relationships. And both are really important, again, to foster resilience, both in children and young people with PTSD and in children who may have other types of emotional symptoms. These interventions are known to be efficacious in treating PTSD, but may also be helpful in preventing PTSD among those who may have symptoms of PTSD. And importantly, once we improve the PTSD symptoms, very often we see that the comorbidities, particularly with depression, anxiety, and in many cases substance misuse, is also reduced, which really highlights the importance of delivering these evidence-based treatments. And importantly also, the evidence supports the efficacy of both individual and group setting delivery for these treatments. The individual treatment is typically more efficacious, but treatment that is trauma-focused and delivering group settings, for example, the teaching recovery technique that I know has been also adapted and applied in Ukraine, can be efficacious. And now we have good evidence from meta-analysis that this is the case. And this is really important, of course, because these are then interventions that can be applied in a more scalable and sustainable way. Now, I also want to mention psychopharmacology to hopefully clarify some questions that I often am asked. And the first thing to say is that there is no evidence for the efficacy of any psychopharmacological intervention on PTSD in young people. So the primary intervention for PTSD is through psychotherapy. This is not to say that it's unusual to see pharmacotherapy used in children and young people with PTSD. But the evidence is really for the efficacy of pharmacotherapy for emotional disorders, for example, depression and anxiety, that, as we have seen, could be comorbid in the presentation with PTSD. So again, the message is that we cannot treat PTSD with medications, but medications can be helpful. For example, if a child is too depressed to engage in treatment or too anxious to attend treatment. Sedatives and hypnotic medications have been used quite a lot in PTSD for all sorts of reasons. In terms of the evidence, I think it's reasonable to suggest that there might be some pragmatic short-term strategy where the use of sedatives and hypnotic may be helpful, but they require monitoring, and there is, again, no evidence for improving long-term outcomes, particularly related to PTSD. And in some cases, they can have detrimental outcomes even. So as a summary of this section on treatment, clinicians can provide psychological support by producing accessible, evidence-based information on emotional coping skills and reaction to psychological trauma that can be distributed at population level. So they can contribute in that way. They can contribute also coordinating and supervising other professionals working with young people. Clinicians can help coordinate groups or individual-based psychological first aid interventions for at-risk children and families. We saw that there are effective psychological treatments for children who develop trauma-related psychopathology, and pharmacological interventions for PTSD have little evidence base, but can be helpful for mainly comorbid disorders. I wanted to highlight some challenges that likely are relevant in this context. One is to think about what is the best way to plan for clinical training and supervision in child and adolescent mental health and in this specific area of psychopathology. This is important because the task shifting mechanisms that we have alluded to requires, of course, importantly, the presence of training as well as clinical supervision that needs to be ongoing. It's important that any interventions, including very low intensity interventions, such as psychoeducational materials, are safe, helpful, and engaging. And this is something that I think has to be tested and monitored over time. It's important we talked about the barriers to seeking and receiving assessments, but equally, of course, there are many barriers, the same that we have discussed earlier, that can also impact and reduce the ability of children to access treatment. Again, psychological, cultural, and structural barriers that need to be mapped and addressed if safe and effective treatment can be delivered. And finally, the idea that we need to really think new ways in which effective interventions can be delivered in a scalable and sustainable way. And I mentioned that the evidence that group-based psychological intervention can be effective is really promising in this area, and very much the focus of research and clinical research and applications at the moment. So for those interested, I will highlight just a few publications that expand on some of the things that we discussed today, including this chapter on trauma-related psychopathology, published in an open access textbook from ESCAP, so an international association of child and adolescent psychopathology, a blog that we had written on trauma for the Association of Child and Adolescent Mental Health, and an editorial that we wrote back in 2019 before the pandemic and before and that really set the framework for a public health response and the role of child and adolescent mental health professional in the context of emergencies and disasters. And these are things that might be helpful also to expand on this. And finally, I want to thank my colleagues at our National and Specialist CAMS Clinic for Trauma, Anxiety, and Depression that have shared with me much of this work and really have been an inspiration and support in developing this work. And thank you very much for your attention.
Тут є таке питання від пані Катерини Чернишової. Чи потрібна адаптація перерахованих скринінгових тестів для українських дітей? Чи їх можна просто перекласти та використовувати? Що скаже Андреа?
Yeah, so I think there are already translated and validated screening materials that have been used, both in clinical settings as well as in research settings. So the publication I showed about the prevalence, for example, of psychopathology has used some questionnaires. So this is the reference for that publication. They have used some translated measures. And I know that colleagues have, for example, translated one of the screening methods I recommend for PTSD in Ukrainian, including, I just bring it up here again so you can see it, the Child Revised Impact of Event Scale. So I know that there is a Ukrainian version that can be used for assessment. Yes, and we can definitely look for references and links if that's of interest.
Так, є такі коментарі від Ольги Казакової в клінічному протоколі, що в липні вийшов, є перелік та рекомендації МОЗ, але потім пані Ольга пише, що кожен інструмент і тест треба спочатку стандартизувати і валідизувати в Україні на нашій вибірці. Чи, ну, про стандартизацію і валідізацію розумію, а чи потрібно це робити саме на нашій вибірці? Чи це правильно? Мені здається, що ні. Те, що
насправді Дякую, Катя. Насправді це регламентується Державним експертним центром, і я також не впевнена в тому стосовно вибірки, про те, що ви говорите, але ми попросимо консультацію від Державного експертного центру. Я думаю, що тут трошки простіша процедура.
Угу. Так, дивимось, що в нас ще з питаннями. Більше питань я наразі не бачу, тому ті, в кого є питання наразі, будь ласка, напишіть їх. Пані Ірино, чи у вас є питання до Андрея?
Ні, дякую, в мене немає питань, в мене тільки є слова вдячності за інформативну, цікаву і вкрай важливу для нас інформацію. І те, що ви щиро ділитеся своїми знаннями, своїм досвідом, методиками, це також ми знаємо, що Королівський коледж психіатрії – це та організація, яка, скажімо, є законодавець провідних методик лікування, напрацьовує протоколи, працює з професійною спільнотою, тому ваша участь в нашій програмі є дуже цінною. І ще раз дякуємо і професору Фегерту, і асоціації, і вашій особі, Андреа, також.
Є питання в нас ще від слухачів. Дар'я Навахуст питає англійською, тому я буду зачитувати англійською. Is there any evidence suggesting that childhood PTSD can lead to epigenetic changes? If so, how might these changes impact future generations?
Yes. Epigenetic is a very interesting, novel way of assessing the potential impact of stress, including post-traumatic stress disorder on bodily biology. I think the most interesting findings at the moment are on animal models rather than in human studies. In animal models, we can more confidently point to causal effects of experiences and distress on epigenetic changes. Of course, rodent models, so models in mice, are quite different from how our physiology works. So it's important to understand and test how these hypotheses are relevant to human physiology. And I think we have an interesting set of observational research looking at the associations, for example, of PTSD, but also of other types of psychopathology with epigenetics. At this point in time, I don't think we can confidently say that these effects are necessarily causal, and so make strong inferences, for example, on the epigenetic inheritance of any of these effects. But it's definitely an important area for research.
Є такий коментар від пані Олени Джули, що ми маємо шкалу впливу подій і CAT-2 і діагностичні критерії. І маємо коментар від Ольги Казакової, що в клінічному протоколі, який з липня, там є окремо діти 3-6 років і окремо діти 7-17 років. Може, Андрея хоче щось прокоментувати з цього?
Sorry, I'm not sure what I'm asked to comment on.
Є розділ в нашому протоколі, який є мозівський протокол, там діти поділені на групи 3-6 років і 7-17 років. Чи так треба ділити вікові групи в підходах?
Yeah. So I think using age-related approaches is pragmatically very helpful. And it makes sense in terms of thinking about the cognitive capacities that are typically developed at those ages. I would say that it's also important to consider the developmental stages at which children are at. so that, for example, two children of 10 years old might present with quite different cognitive abilities. And so it's important to understand their cognitive abilities and the way we then try to adapt the treatment interventions. And of course, there are particularly, well, both in terms of assessment and in terms of treatment, there are some adaptations that are necessary. So we tend to, for example, assess symptoms of PTSD, but also depression and anxiety through parental report until about 7, 8 years old, if not later, because children may not be able to conceptualize the symptoms and report them. Parents tend to under-report the symptoms. So my suggestion would be to try and combine parental and child report, even in young children, if possible. And in terms of treatment, of course, the treatment also need to be adapted for the same reason, that younger children and children at earlier developmental stages may not be able to, for example, understand very abstract concepts. And so the way we deliver, for example, trauma-focused interventions need to be simplified. This is true for younger children, but also we're discovering more and more for also neurodiverse children. So children and young people who, for example, also have diagnosis of autism.
В мене є питання, якщо можна. З якими складнощами і з якими, скажімо так, інсайтами ви стикаєтесь, працюючи з батьками дітей?
That's an excellent question. And so I would say particularly in your context, a major concern would be parental mental health for a number of reasons. But focusing particularly on children, it's really important to understand how parental psychopathology might impact both on the presentation of psychopathology in children, but also may be a barrier to treatment outcomes. So if parents, for example, also have PTSD, it might be harder to have successful treatment outcomes of PTSD in children and young people. And therefore, when here in the UK we have worked with children and families involved in community emergencies and disasters, we have done as much as we could to address those issues at the family or community level, so that we aim to build teams that were multidisciplinary in the way that involved both child and adolescent mental health professionals as well as adult professionals. And the feedback from families is that that has been extremely helpful.
Jörg, would you like to comment something?
There are also important things that, of course, we can say about parents as potentially providers of treatment or collaborators in providing treatment for their children. And there are very extremely good protocols for parental delivery of treatment in the case of anxiety disorders. There is some current research in adapting those protocols to other types of conditions, including PTSD. So I highlighted both the challenges, I guess, of working with parents, but also the importance of involving parents in assessment and treatment, because, of course, the parents are not just providing the environment that children live in, but will be able to deliver some of these interventions in the right way.
Professor Jörg?
Yeah. Yes, in a study on trauma-focused child therapy, we did a long-term extension. And part of this therapy is very good information of parents or caregivers about the trauma symptoms, like Andrea explained to you. And what we found in comparison to adult data, that is that therapy success was much sustainable in children much more sustainable in children compared to adults. And I think that's the role of parents. If they learn to understand what's going on and to support the child, they have a very, very protective role. And as I told you some weeks ago when I did the first webinar, when we see here in Germany refugees, minors, children accompanied by their parents, usually the parents can really protect these children from major symptoms of trauma, even if they live through very dramatic situation. And it's a different situation to unaccompanied minors who are really exposed and have nobody to talk about. So parents play really, I think, and I agree with Andrea, play a very important role.
Beyond that, if I can add, here we were talking about, you remember I showed you a pyramid of needs and intervention. We were talking about the top of the pyramid, right, where we aim to treat symptoms. But just building on what Jörg said, parents are essential to build resilience, so that they can have a very impactful effect in the population to reduce the onset of disorders and also to reduce the amount of symptoms in the population. So they are the most important allies, if you like, of mental health professionals when, of course, they are in conditions of help.
So, thank you very much, both Andrea and Professor Fegert. Пані Ірина, чи ви б хотіли якось завершити, бо я не бачу більше питань поки що. Пані Ірина.
У мене також питань немає, в мене продовження ще раз. Вдячні за такий хороший, таку добру комунікацію, таку якісну інформацію. У нас величезна кількість учасників залишається далі в ефірі, і це свідчить про те, що вкрай висока є зацікавленість до доказового матеріалу, який ви нам презентуєте, представляєте, для того, щоб ми опрацьовувати будемо далі, адже це вкрай важливо навчання наших фахівців. Сподіваюся, ми з нетерпінням чекаємо на наступні зустрічі, і мені дуже приємно, що наші учасники зараз буквально заспамили чат словами вдячності нашим шановним спікерам і Європейському товариству дитячих психологів. А наших колег запрошую працювати з тою інформацією, яку ви отримували, впроваджувати її в свою щоденну практику і вчитися більше і більше для того, щоб брати участь і в наступних наших проєктах, і в тому числі в міжнародних активностях, семінарах, конференціях, конгресах, і отримувати новий досвід і ділитися тим досвідом унікальним, який сьогодні ви маєте вже в Україні.
Дякую, пані Ірина. В нас на площадці в Zoom було під кінець 338 учасників. Це прям дуже активні люди, які в вечірні часи дивляться нас прямо в онлайні. Потім ми знаємо, що люди додивляються ще в YouTube, тому ми дуже всім вдячні, хто нас дивився. І дякуємо професору Данезе і професору Фегерту за участь в цьому вебінарі. До нових зустрічей швидко, скоро. Дякуємо. Гарного вечора.